Okay, so we're going to continue with the cranial nerve exam, and we know that there are 12 cranial nerves, and however you choose to remember these, put them in your head, use a mnemonic. A lot of mnemonics out there you can use. I always remember on, Ol, Olympus, Tau, and Tops, A, Fin, and German View, Chum, Hops. Okay, and that's what I use to remember, but there are a lot of mnemonics. Whatever sticks with you, use that one. Okay. I also want to point out that the cranial nerve, the 12 cranial nerves, some have only a motor component, some have only a sensory component. You have to know, and some have both. So you have to know if the cranial nerve you're testing has only a motor component, or if it has only a sensory component, or if it has a motor and a sensory component. So you really have to discern that before when you're testing, so you know if you're testing all aspects of function for that cranial nerve. So you want to make sure. And a mnemonic I use to remember that is, some say marry money, but my brother says big brains matter most. Okay, so that's how I remember it. And if you want to look at it, so we're going to start with cranial nerve 1, which is olfactory, some, and then we have cranial nerve 2, which is optic, which is a say. Then we have cranial nerve 3, which is oculomotor, marry, which is motor, and then cranial nerve 4, which is trochlear, motor, money, that's again motor. But cranial nerve 5, trigeminal, both, motor and sensory, both. And then that's cranial nerve 6, abducens, which is motor only again, which is an M. Brother, cranial nerve 7, which is both, which is a B. Says, cranial nerve 8, which is S, which is sensory. Big, which is cranial 9, which is both. Brains, cranial nerve 10, which is both. Matter, cranial nerve 11, which is motor. And then most, cranial nerve 12, which is motor. Okay? So we have all the cranial nerves here, and we have to go through whether it's motor or sensory. Okay? This diagram actually just shows you where the cranial nerves are. Remember earlier we discussed that there are 2 cranial nerves in the cerebral hemispheres, which is cranial nerve 1 and 2. Every other cranial nerve are in the brainstem. Okay? We have cranial nerve 3 and 4, which is in the midbrain. Cranial nerve 5, 6, 7, and 8, which is in the pons, and then cranial nerve 9, 10, 11, and 12, which is in the medulla and the lower part of the brainstem. Okay? And these are your names: optic, olfactory, optic, oculomotor, trochlear, abducens, trigeminal. Then you have your, what do you call it? Where's cranial nerve 6? Abducens, I said that. Then you have your facial, then you have your vestibular trochlear, which is cranial nerve 8. Then you have your glossopharyngeal, which is cranial nerve 9. Then you have your vagus, which is cranial nerve 10. Then you have your accessory, your spinal accessory, which is cranial nerve 11. And then, where's cranial nerve 12? You have your hypoglossal, it's here somewhere. Hypoglossal, which is cranial nerve 12, which is here. Okay? And this actually tells you, based on the cranial nerve, which organs are innervated by each cranial nerve. Okay? And if you look at cranial nerve 8, it's hearing. But look at cranial nerve 9 and 10. These are your vagus or your vasomotor kind of innervation for cranial nerve 10, which is your vagus. And cranial nerve 9, which is glossopharyngeal, is your swallowing reflex. So you have cranial nerve 9, which is swallowing in the mouth, and then cranial nerve 10, which is your vagus, which is involved in a lot of your cardiac function and abdominal function. These are what are innervated with your autonomic nervous system. Okay, so heart, lungs, bronchial, gastrointestinal tract, all these are innervated by cranial nerve 10, your vagus nerve. Okay, and remember your vagus nerve is both. It has motor, which is heartbeat, respiratory function, peristalsis of the gastrointestinal tract, and then the sensory, also heart, lungs, bronchial, laryngeal, pharyngeal, and gastrointestinal tract. Cranial nerve 9 and 10 are often tested together, so when you're doing your testing, you don't need to say, well, I'm testing cranial nerve 9 and then 10. Just say you're testing cranial nerve 9, 10, and 12, and when you're in the mouth anyway, so you just continue testing all those together. So you're going to test them almost as a unit. You're doing different things to test them, but testing them as a unit works much better. Okay, your vestibular cloak here, that's hearing in your ear. Your trigeminal, which is your trigeminal nerve. Hypoglossal, which is cranial nerve 12. I think we kind of touched on everything here. This is a really busy slide. If you have time, just go through it. It basically reiterates what's on the other slide, but it's really one of the busiest ones. What I like about it is if you look over here, you'll see your mnemonics that you can use. This is another one, ooh, 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 to touch and feel. Very green veggies, ah. Okay, and then you have some say marry money, but my brother says big brains matter most. Okay, so you have 2 mnemonics here. You can actually use them to remember the cranial nerves, the names, and the actual function, whether it's motor or sensory. Okay, that's probably the best thing you can get from this slide. And then cranial nerve 3 up there, and it tells you how to test some of them, but it's a very busy slide, so you can actually use it. Okay. This chart is going to break down the cranial nerves. So we talked about cranial nerve 1 being olfactory, that is smell. If you have no sense of smell, this is nausea. So it's agnosia, which is the lack of smell. Cranial nerve 1 is not normally tested when you're testing cranial nerves. Why? Because it usually it's very hard for cranial nerve 1 deficit. It happens in clinical practice a lot in traumatic brain injuries. We talked about it, we showed in the picture that we looked at that cranial nerve 1 is at the base of the brain. So a lot of times in traumatic brain injury, when the brain is jarred, it can actually shear or tear cranial nerve 1, where you have the olfactory bulb here, and you can actually shear or tear that and cause some issues in smelling. Now, testing it, a lot of times you don't do, but in a traumatic brain injury patient who's not eating, you want to know, is cranial nerve 1 working? Why? Because if I smell food, I want to eat it. I get my appetite through how good or bad food smells. If I can't smell the food, the likelihood that I'm going to have an appetite or decrease. So a lot of times you see traumatic brain injury patients who are not eating, you want to check to see if they have a good sense of smell. And that's what you're going to do. How do you test it? You have the patient occlude the nostril, close their eye, and then you're going to introduce to them a familiar smell, like coffee. You don't want to use something toxic like ammonia, because it can actually burn, so you don't want to use that, but you can use something like coffee, which is a very familiar smell, even though I've had a patient who's like, well, I don't really know. And I'm like, how do you not know how coffee smells? It's like, well, where I live, don't really have a lot of coffee, so you want to make sure you find that out first too. So you want to find something that's familiar to that person. You can use vanilla, things like that. And then you can have them smell it and identify the smell. Okay? Now, cranial nerve 2 is a sensory type nerve. It actually is optic and is checking vision. Now, when you're checking cranial nerve 2, there are lots of ways, okay? It's not just one thing you're doing. The Snellen chart is checking vision, so that's a part of cranial nerve 2 assessment. When you're doing confrontation and checking peripheral vision, that's also a part of cranial nerve 2, the optic. The fundoscopic exam is also a part of cranial nerve 2, okay? So all that is cranial nerve 2. The pupillary light reflex, cranial nerve 2 receives the light reflex and cranial nerve 3 constricts the pupil. So cranial nerve 2, part of checking cranial nerve 2 is the pupillary light reflex. So cranial nerve 2 and 3 is responsible for checking, when you're checking the pupillary light reflex. It's not just cranial nerve 3. Okay, so you want to remember that. Cranial nerve 3 is ocular motor. It's actually motor. So you know that there's no sensory component to this. This is only motor. And this is the efferent part of the pupillary reflex. So the afferent part is the light goes into the eye, okay, and then the brain sends the signal to constrict the pupil. So that's the efferent part, the pupillary constriction. Now, cranial nerve 3 also moves the eye in several directions, okay? It's the oculomotor nerve. So when you're checking your cardinal fields of gaze, you're checking cranial nerve 3, okay? Cranial nerve 3 moves the eye medially, so in towards the nose, okay? It's cranial nerve 3. Cranial nerve 3 also moves the eye up and in. So you take it up and in, that's cranial nerve 3. Up and out is also cranial nerve 3. Down and out is also cranial nerve 3. So it's responsible for moving the eye in several directions, okay? If someone has a cranial nerve 3 deficit, they can have a disconjugate gaze. Cranial nerve 4 deficit can give you a disconjugate gaze too, and 6. So you want to look at that, okay? When you're doing accommodation, where you move the finger from afar and then bring it close so you can actually see the pupils constrict and the eyes move inwards, that's also a part of testing cranial nerve 3. So it's all motor aspects. Cranial nerve 3, 4, and 6 are always tested together, again, because you're going to do the cardinal fields of gaze. So we said that cranial nerve 3 moves the eye medially. We said it moves it up and in. We said it moves it up and out. We said it moves it up and down and out. Cranial nerve 4 moves the eye in and down, forward to the floor. People who have a cranial nerve 4 deficit or trochlear deficit cannot walk downstairs because you actually have to look down to actually walk downstairs. So you have to be able to look down and in. So they can't do that with cranial nerve 4 deficit. So they have difficulty walking downstairs. Cranial nerve 6 moves the eye laterally, okay, and that's your abducens. It moves the eye out, okay? So cranial nerve 6 deficit, they can't move the eye out. I want you to understand something. When you're looking at cranial nerve 3, 4, and 6, when you have a cranial nerve 3, 4, or 6 deficit, the eye moves towards the stronger muscle. Okay, so wherever the muscle is stronger or the muscle can be innervated, that's where your eye is going to move towards. So this picture gives you a good example of that. The superior oblique muscle is responsible for cranial nerve 4, so it moves the eye down and in. Okay, you have the inferior oblique that moves the eye up and out. Okay, the lateral rectus that moves the eye laterally. The inferior rectus will move the eye down, okay? So these are the muscles that are actually innervated in moving the eye. If you have a cranial nerve 3 deficit, your medial rectus muscle is what's going to be damaged. Your medial rectus muscle moves the eye in towards the nose. So you look, that would move it in, and that would move it in. So if this is damaged, what's going to happen is the lateral rectus muscle, which is innervates cranial nerve 6, is going to be stronger. So your eye is going to rotate towards the lateral rectus muscle. So someone who has a cranial nerve 3 deficit, the pupil won't be in, it will be rotated out towards the stronger muscle. Okay? If you have a cranial nerve 6 deficit, which is the lateral rectus muscle, it actually moves the eye outwards, laterally, okay? So someone who has a cranial nerve 6 deficit, the medial rectus muscle is stronger, so the eye is going to pull inwards medially, and they won't be able to rotate the eye outward, okay? Same thing. Cranial nerve 4, the superior oblique pulls the eye down and in. If you have a cranial nerve 4 deficit, the eye is going to rotate up, and that is going to rotate up. So that person is only going to be able to look up. They won't be able to look down because that muscle is damaged, okay? So that's how it works, okay? And you have over here a third nerve deficit. Then we said the medial rectus muscle, which pulls the eye inward, is not working here, so the eye is pulled laterally, okay? Then you have a fourth cranial nerve deficit. The eye is actually supposed to be able to move in and down, and look at the eye rotated up and in, okay? And then you have a cranial nerve 6 deficit, where the eye is supposed to be able to move laterally, but the eye can't move laterally, so it's actually rotated in medially on the medial arm, because the lateral rectus muscle is not working, so the medial rectus muscle takes over. So when you have a question on your exam, and let's say for instance you have Mr. Smith that comes in and he has a cranial nerve 6 palsy, where do you expect to see his eye rotated? If it's cranial nerve 6 palsy, remember the medial rectus muscle is going to take over. So your eye is going to be rotated inward towards the nose. Okay? So remember that. It's a really good picture for you to actually take in. Right? Alright, cranial nerve 7. Okay? It has both. Remember, some say marry, money, but which cranial nerve 5, trigeminal, has both. How do you test it? Cranial nerve 5, the trigeminal nerve has 3 branches. You put your hand like this on your face, you can actually, what do you call it? Identify the branches, okay? One goes on the forehead, one goes on the cheek, and the next one comes on the mandible here, okay? And that's your cranial nerve, the 3 branches of cranial nerve 5. That's when you're going to check it through the sensory aspect, where you can actually take a sharp object and a dull object and say, tell me what you're feeling, tell me what you're feeling, tell me what you're feeling. Okay? Is it sharp or dull, sharp or dull, sharp or dull? And you do it on both sides of the face. Okay? Now the motor aspect is actually checking the trigeminal muscles. So you can actually tell them, close your mouth, don't let me open it. Okay, and then you can now actually palpate the temporomandibular joint, put your both hands here, and ask them to open and close your mouth. Okay, and that's checking cranial nerve 5. When do you see cranial nerve 5 deficit? They can actually have numbness or weakness in the jaw. That can be trigeminal neuralgia. They have a lot of pain in that face, and then herpes can actually give them pain following that trigeminal nerve also. Another part of cranial nerve 5 is oh my God, I just went back. It's corneal reflex, I'm sorry. The corneal reflex, you're not going to ever do on someone who's awake, alert. Never, ever, 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 ever. You only test that when you're suspecting that someone's brain dead. And that's what they usually do, is take a cotton swab and wisp it across the patient's eye. And if you wisp it across the patient's eye, with a deficit, the corneal, the sensory of feeling it is cranial nerve 5, and cranial nerve 3 closes the eye, okay? So cranial nerve 3 is responsible for closing the eye, and cranial nerve 5 is that sense, that sensing the pain, or sense the object coming towards the eye, okay? So that, and cranial nerve 3 is involved in the corneal reflex. Again, you do not test that unless you're suspecting brain death on that person. We talked about cranial nerve 6, now cranial nerve 7. Some say marry, money, but my brother, I'm sorry, cranial nerve 7, I keep saying sensory, but it's, no, it's both, actually both. So cranial nerve 7 is both, and it has a motor and a sensory. The motor is the facial muscles, the sensory is the lateral, the posterior third of the tongue, and it is involved in taste, okay? So the taste aspect is the anterior 2/3 of the tongue, I'm sorry, is where the taste is involved. So how you test cranial nerve 7, you can ask the patient to smile, and you're looking for symmetry of the face, facial muscles. Remember, you can have a cranial nerve 7 peripheral or central. A central cranial nerve 7 deficit, meaning that it's coming from the brain, will give you the lower portion of the face weak. If it's coming from a peripheral deficit, something like a Bell's palsy can give you a peripheral cranial nerve 7 deficit, and it's the entire face that's going to be weak, not just the lower part. So the lower part, you're expecting something in the brain, such as a stroke or a brain tumor, but a peripheral, with the entire side of the face is damaged, and then those people have difficulty closing their eyes, they have the whole facial weakness, then that person has a peripheral nerve deficit, a peripheral cranial nerve 7 deficit. Okay? Okay. Cranial nerve 7 has some acoustic components also. It's damaged. You can actually hear really, really loud noises. But again, it's not normally tested. You have to be like in a neurologist's office testing that, depending. Okay? So cranial nerve 8 is your vestibular trochlear. And how do you test cranial nerve 8? This is where you're testing hearing. So you're looking at, can you hear me? Can you hear that? Can you hear that? They can do the whisper test, the finger click. Weber and Rhine, when you actually take the tuning fork and test hearing, that's also checking to cranial nerve 8, okay? And that's checking hearing. And it's a sensory part. You can have a conductive versus sensory neuronal hearing loss. And sensory neuronal usually means that there's inner ear damage. Conductive hearing loss is usually due to some kind of obstruction where there is something that's causing the sound to bounce off of, okay? And so you can actually test that. Tinnitus, vertigo, and nystagmus are associated with vestibulocochlear deficits, and you'll see that in things like Meniere's disease. Will give you the nystagmus, I'm sorry, not the nystagmus, the tinnitus, and you can have dizziness associated with it, because a little bit of balance is associated with vestibulocochlear also, okay? So equilibrium, balance, all that associated with vestibulocochlear. Cranial nerve 9, which is your glossopharyngeal, sensory and motor. Cranial nerve 10, which is vagus, which is sensory and motor. And again, when you're doing your exam, you're testing in the mouth already, so you're going to test cranial nerve 9 and 10 together. Cranial nerve 9, glossopharyngeal, you're looking at the posterior aspect of the mouth, and this is when you're going to ask them to open their mouth wide. You're going to ask them to say ah. You're going to look for the palate, the symmetry of the palate. You're going to look for the uvula and see it usually rises. Some people have it off to one side, and sometimes you see that with someone who's been intubated before. It can be stretched and moved to one side, so you're going to look at that. You're going to ask them to say ah, have them swallow. Phonation is checking when they ask them to say ah, so you can hear if they have good phonation. The gag reflex you can check with cranial nerve glossopharyngeal. We're not going to do that in our exam. We don't do that to people who are awake. We do that to people who we think may have some brainstem compression. So we don't normally gag someone. Okay? Cranial nerve 10, again, you're doing the same thing. Uvula, soft palate, move symmetrically. You're going to ask them to say ah, all that. You're looking for hoarseness. You're going to look for paralysis of the palate or uvular, deviating to one side. That's what you're looking for when you're checking cranial nerve 9, 10. Difficulty swallowing, gagging, things like that. No gag reflex, things like that would indicate that brainstem dysfunction is eminent, okay, or there. Cranial nerve 11, your spinal accessory, you're checking your sternocleidomastoid and your trapezius muscle strength. So this patient, you're going to have them push put your hand on one side of their face and have them push towards you, and the other side, that's checking your sternocleidomastoid, and then you can tell them, put my hand on your shoulder and shrug up, and that's checking your trapezius strength, okay? Cranial nerve 12 is hypoglossal, and that's checking tongue movements. You can actually tell them move their tongue from one side to the next. Cranial nerve 12 sometimes can get implicated in someone who have, what do you call it, carotid endarterectomy. Sometimes that nerve is peripherally retracted during a carotid endarterectomy, and they can have numbness on one side of their tongue post the procedure. Okay, so that's your cranial nerve, cranial nerves. You have all 12. Remember, sensory, motor, or both. You want to make sure that you're checking both the sensory and the motor aspect of the nerve. You don't want to test one without the other, if they have both, okay? Your motor exam. When you're doing your motor exam, there's a standardized motor scale for our patients who have a motor assessment. You don't want to just say that the patient has full strength. What does that mean? That can mean a lot of different things, okay? So you have a cranial nerve, you have a motor assessment tool, and that goes from 0 to 5, okay? 0 is no movement. 1, you can have muscle contraction. 2, they can move their hand or leg across the bed, but not against gravity. 3, they can move it against gravity, but not against resistance. 4, they can move it against gravity and resistance, but it's weak. 5, it's full strength against gravity, against resistance, and that's the standardized motor scale that you should be using. When you're doing your motor exam, you want to assess muscle size, because you want to see if there's atrophy of muscles. Someone who's not moving around may have atrophy. You're going to check muscle tone, so you're going to check for spasticity or rigidity. You can do that with someone who has brain injury. So they may be spastic. Rigid persons who would be something like Parkinson's disease, you want to check for those. You're going to assess muscle strength. A lot of times you can check for a drift. Have them both of their arms up in front of them and tell them to close their eyes and keep their arms up. You're going to count to 10, and if their arm starts dropping down one arm, then you see that they have a drift, okay, and that would indicate that there's some weakness in that muscle. Okay, this is a standardized muscle scale assessment that we talked about, and if you can go through it, okay. Proximal weakness versus distal. Remember, proximal is anything close to the body. Distal weakness is anything away from the body. Your proximal muscles would be like something like your deltoid. That will give you weakness. That will give you the issues lifting your arm over your head for the upper extremities, lifting your leg off the bed for your lower extremities. Distal would be different things like writing for your upper extremities, and then walking for your lower extremities, because your distal muscles will be things like your tibialis anteriors, which actually cause your legs to flex or extend, which is your gastrocnemius, and you want to make sure that those are strong too. So distal versus proximal can have different issues with patients. And distal muscle weakness, a foot drop, tibialis anteriors, you can't flex. You can't flex the foot back. I'm not sure if you're able to see my foot, but you can't flex the foot back like this. That's a patient who can't do that would have a tibialis anterior muscle weakness. Gastrocnemius is that they can't push down. So you can't press on the gas pedal. And a lot of times patients who have those will walk and they drag their foot. So you'll see them, they have what we call a steppage gait, because they're walking and they're lifting their foot in order for them to walk. Okay, and that will give you like a steppage type gait. Muscle tone, class 9 phenomenon, cogwheeling, paratonia, lead pipe resistance, all these can be associated with different disease processes that can give you these. The ones that you see a lot is cogwheeling. You see that with your Parkinson's disease. They'll have cogwheeling. Some of these you can see with people who take a lot of dopamine blocking drugs, so your psychiatric patients, your schizophrenic patients, you may see some of these rigidity in them, okay? Coordination, you're checking coordination for cerebellar function. So you can do several things, okay, to check coordination. You can do finger to nose to finger. So you can tell the patient, I want you to touch my finger and then touch your nose and touch my finger again. That's the finger to nose to finger. You can actually have them do where you can have them take their hands and just go like this. Okay, they should be able to have good smooth transition between fingers. Okay. Another thing is you can tell them move your hand forward and backward as fast as possible. Okay. Then you have heel to shin. Okay. Where they can actually put their heel on the top of their foot and rub it all the way to the knee and then bring it back down. And they should be able to do that in a smooth pattern. Okay, so that's heel to shin. So you have finger to nose to finger, rapid alternating movements. They can do this, they can do that. They can actually do this too, where they knock on their legs, bring their arms back and forth. Any one of those in your exam, when you're doing your competency exam, you will have to incorporate either finger to nose to finger, heel to shin, rapid alternating movements, any one of those that you can incorporate. Okay, you only have to do one, so you can choose whichever one you feel more comfortable with. But all of these check cerebellar function. If they have ataxia, they may not be able to smoothly touch my finger, touch your nose. They may be moving my fingers there, and they may be moving over here like that, or coming back to the nose, they're going like this before they can get there. Okay, and that's some ataxia. Okay. You can have unsteadiness. Etiology is abnormal proprioceptive input from the lower extremities. You can have sensory ataxia and motor ataxia. Sensory ataxia, usually they don't feel their feet, so when they're walking like this. Okay, it's a wide base stance that they're walking. Okay. And they motor ataxia, wide base, irregular planting of their foot, so they're walking almost like they're drunk, kind of sort of, but wide base gait can be associated with that. Okay, these are your different types of gait. Your steppage gait, you see it a lot with a foot drop. You see how she's bringing her toes up, and she's trying, and when she walks, she's going to be like doing like that to drag her foot. Your propulsive gait, you see that a lot with your Parkinson's type patient. Your spastic gait, that can have a spinal cord injury, can be associated with it. Some people with hip dysplasia can have a spastic looking type gait. Okay. Your scissor gait, you see it associated with some brain injuries. You can see it with your waddling gait. Hip dysplasia will give you your waddling gait also. So it depends on what's going on. You really have to work the patient up. I don't think anything specific. You can have a steppage gait issue just by having a lumbar disc herniation, which compresses that nerve root that innervates that muscle. Your propulsive gait, you see it a lot with Parkinson's though. Okay. Characteristics of gait, hemiplegia. We know that strokes, tumors, brain bleeds, anything can give you weakness on one side of the body. So a hemiplegic gait, one side of the body is weaker. Remember, you have hemiplegia and hemiparalysis. Hemiplegia is weakness. That means that it's not functioning optimally. Paralysis means that it's not moving at all. So you know the difference between plegia and paralysis. Okay. Parkinson's, when you have a Parkinson's gait, they have a shuffle gait, so they're walking and their feet are shuffling, like they're moving, I'm not sure I'm explaining it, but if you can see my hands, this is usually how they shuffle. Okay, the cerebellar ataxia, that's like your drunken gait, that's a wide base stance. The foot drop is when you're dragging your foot and lifting it up. I wish we could actually show a foot, but I'll do another video so you can see those. And the sensory ataxia, a lot of times they can't feel, and you see that with a peripheral neuropathy. They can't feel where they're putting their foot, so they walk like there's a wide base gait stance also. You see that with peripheral neuropathy, people who are diabetics, who have arterial disease. When you have a sensory ataxia, where they're not feeling their foot, you want to check for arterial insufficiency in these patients, okay? A lot of things can cause gait disturbances. You can have a pathological disease like Parkinson's, you can have stroke, you can have hip problems.